Good evening. My name is Jacqui Fletcher, and I'm the clinical lead for pressure ulcers for NHS England. And I'm going to be your chair this evening. And I'm delighted to welcome you to our Stop the Pressure Down webinar, which is focusing on the prevention of pressure ulcers in people with dementia. As part of this year's theme of inclusivity, we wanted very much to focus on groups of patients who may be overlooked, but remain very much at risk of pressure ulcers. So far this week, we've looked at paediatric patients and those patients with learning disabilities. Both of these webinars are available online to watch if you have not yet seen them. But tonight, we wanted to focus on a large and growing population of people, those people who are cared for in our multiple care settings, frequently in their own homes, with care provided by family or social carers, or people who might be in a general or specialist care home. For these people with dementia, there are significant challenges associated with pressure ulcer prevention, and I'm delighted, therefore, to be hosting this webinar this evening. We have a very varied panel of speakers, and because we wanted to reflect the different care settings and the different care professionals that may be involved in communicating these people's needs and the delivery of appropriate care. We are hoping that two more panel members may be joining us shortly, but they are, as often happens with these things, having some technical difficulties, so they may join us. But I'm delighted that we have two of our panel members to welcome. We have Christopher Cairns and Abby Yates, and I'm going to ask them to introduce themselves. So Christopher, would you like to go first?
So hello, I'm Chris Cairns. I work at South Tyneside and Sunderland NHS Foundation Trust, which is an acute trust, and I work largely within the acute setting as a nurse consultant for older persons. My role is quite varied in that I carry out work with people who have dementia and delirium in the inpatient setting, but I also run clinics as part of a memory diagnostic service that we do within the hospital. I've worked within dementia and delirium care for most of my career. It's something I very much enjoy, and I think I jumped at the opportunity to have this discussion today just to further the care that my group of patients receive.
Thanks, Chris. Abby.
Hello, everybody. My name is Abby. I'm a speech and language therapist, and I work for Nottingham University Hospitals Trust, which is also an acute trust. I've been qualified now only a year and a half, so absolutely open to admitting that I don't know everything there is to know about speech therapy or pressure ulcer prevention, but I'm very passionate about the role of communication in every element of the care, whether that's acute care, community care. So I hope I can shed light on that during this session today.
Thank you both. And I think that's really great to see that breadth of experience we've got from Abby, who's quite new in her journey, through to Chris, who this has been all of his work since his qualification. And I just wanted to put a little bit of context into my views on this, because I'm a specialist in tissue viability. I'm certainly not a specialist in dementia. And I know some of my experience of interacting with people and their carers of people with dementia have been frustrating, unsatisfying, and that's not necessarily about their communication. It's sometimes about my feeling that I haven't been able to do my best for that person because we weren't able to get into the right position. And I think that I'm probably not unusual, that for most generalist clinicians, that provision of preventative care for a person with dementia can be quite anxiety provoking. We really want to do our best, but we're really worried about upsetting the person, causing distress to them, and really concerned about how we get them. And I'm going to use the phrase to comply. And we know that, that's not what we're aiming for. We're aiming for concordancy in care. But it is quite often that frustration of you think you've had a good conversation, you think you've had a sensitive conversation, and you turn around and everything that's just been discussed may as well not happen. And for me, one of the things I think about any clinician that works with dementia is I cannot underestimate the level of patience you have. To me, it's a job where you feel you're constantly repeating yourself to achieve the same goal. So I find that really difficult. I have to go into the situation doing that. Let's be calm, because it's all about not getting upset so they don't get upset. So before we move on to some specific questions, Chris, do you think you could just give us a little bit of background, set some context for us about dementia and where we're at with the general population?
Yes, absolutely. So interestingly, when I first started working within dementia care, there was 850,000 people in the UK with dementia. And recently, several years ago, I had to update those figures to 944,000. And actually, I've just had a quick look before this webinar just to make sure I was totally up to date with my stats, and it's saying 988,000 on the latest figures. Dementia is certainly set to significantly increase over the next few years. That's largely due to the aging population. And I think if I think back to when I first started working in our care of the older persons department, the admission criteria was 65 years old. I consider that incredibly young. It is now 75 years old, and I'm frequently working with patients who were 90, 80, 90-year old. In fact, I had a 95-year-old in clinic today, and it's just part of our bread and butter. And I think what's wonderful is that these people are living longer, and they're living sometimes fit and healthy lives, and actually mobile. But unfortunately, the biggest risk factor for dementia is age. And, 1 in 3 people in the UK are expected to suffer from dementia prior to their death. It is now the leading cause of death in ladies. And in fact, Alzheimer's, 2/3 of patients with Alzheimer's are female. Um, at the moment, I think in terms of treatment, we're limited. We're still using drugs that were first commissioned 30 years ago. There has been some developments lately, but I think we're still a long way off, curing this. And within a hospital setting, approximately 50% of our patients that are admitted are confused, 25% dementia, 25% delirium. And so, in fact, most people who've worked in healthcare or in social care, no matter what department you've worked in, as you've alluded to yourself, you will be working with people with dementia. And so I think it's very important that we get it right for these group of people, because it's ultimately going to affect us or our families at some point in the future. It's going to touch everybody. And I think, I would like to think that my mother and father are going to be well cared for. And I think, that's why, doing our best is so important. It's why I get so much gratification out of my role.
Thanks, Chris. That's a really good context for us to think about, and particularly the age-related factors and that real variety of where these people are in different levels of the disease progression. One of the things we talk about a lot in pressure ulcer prevention is the complex nature of our patients. Most of them have a multimorbidity, they're on multiple medications, and they're increasingly frail. Does that tie in with what you see in your patient group?
Absolutely. I think frailty and dementia, in particular delirium, that often gets overlooked, goes hand in hand. By the time you move on to the advanced stages of dementia, 40% of our patients have got pressure damage at that point. And while some of that is due to dementia, a lot of it is due to the progressive frailty that accompanies the illness. And I think what I commonly find is that as people's health deteriorates, their cognitive health also follows suit with that. And people who suffer from, for instance, hip fractures, often get deliriums after the hip fractures. And what we're finding is, if research shows about 1/3 of them are left with cognitive problems. And so things like falls and mobility problems that lead to pressure damage as well, and increasing frailty contribute to these syndromes. So it tends to go hand in hand. And actually, when we first started our inpatient diagnostic service in the hospital, we initially said we would take on the simpler of patients, but as a consultant psychiatrist, there is no simple patient. And I think he's absolutely right. We bring people in for our memory clinics, but quite often we're looking at them for other factors and other health factors, whether that be pressure damage, whether that be mobility problems, whether that be falls. And in fact, I refer as many people to the falls clinics, for instance, as I would do diagnoses. So it's definitely walks hand in hand with frailty.
You talked about cognitive problems there, and that's really one of the things we're really focusing on for Stop the Pressure Day this year, is how
Yes.
we have that communication strategies. Abby, I know the unit you've been involved, you working has been very involved in that ability to understand and make decisions. So some of the things we do for pressure ulcer prevention, the skin inspection, the repositioning, can be seen by somebody who is maybe a little bit confused as quite invasive, quite antagonistic. And one of the things we hear very commonly from our clinicians is that they go to reposition, they go to skin check, and there's a refusal of care. Is that something that you see a lot?
Absolutely, and I think it's difficult. My experience working on some of the wards for people with dementia at work is that there's a real discrepancy between people wanting to deliver person-centered care, and that with then marrying that with wanting to do the right thing for that patient without distress, and managing the conflict between those two things. So although repositioning a patient may be the in their best interest, actually carrying out that action is a different story, and there are things that we can do to try and mitigate refusals or mitigate those escalations where somebody is trying to do something for a person living with dementia. I guess de-escalate the situation. And I think a lot of the focus from what I see on the wards is people will try and de-escalate the situation once it's already started, once the person has already said no. And it actually starts a lot from just how you present yourself when you start that interaction with the patient. It's very difficult in our wards, particularly over winter, but I find now that winter pressures are everyday pressures. It's busy, and our nursing staff, I can see, are under a huge amount of pressure to go in and get things done. Our nurses are looking after more and more patients at one time. I think it's important to try and consider your interactions from the get-go with that person, making them feel safe, making them feel comfortable, before you then go to and instigate that care that you're going to deliver. A good example of this would be just introducing yourself, the real basics. Even if you have previously introduced yourself to that person 5 minutes before, we know that obviously people with dementia may not recognize people. So going and introducing yourself, and approaching that person with not just friendly words, but also a friendly demeanor. I think people underestimate the power of nonverbal communication. And actually 70% of our communication is nonverbal. It comes from our expression. It comes from our body language. I think that's incredibly important and not something to be underestimated. I think providing people with dementia with the comforts that they have at home as well. A lot of my patients will have things that they take with them to scans or procedures, things like teddy bears. The simplest thing can actually make somebody feel more relaxed and more at home. The thing that comes to mind when I speak about things like this is Kit Wood's person-centered care flower for people with dementia. I'm happy to link into the chat, but there's lots of different petals around this flower that has things that people with dementia may need to feel cared for. And I always love this because the petal or the bud in the middle is actually the word love. And I think it's so important to make these people, even if they are strangers to you and you're strangers to them, to make them feel welcome and cared for. In terms of negotiating refusal, so one of my colleagues, Rebecca Allwood, was a monumental individual in the Voice 1 study. We're now actually in phase 2. If for anyone that's not aware, that the Voice study is a conversation analysis research group who have taken consented recordings of people living with dementia and healthcare professionals in the acute setting. And then their conversations are analysed by professionals, linguists, speech and language therapists, for example. And they found that that there are a lot of strategies that people use that they feel are the right strategies to use, but they're actually not based on empirical research or evidence. So they had then had a look at the conversation analysis between individuals and people living with dementia, and they came up with a few that were the most effective in negotiating refusals or encouraging people to engage in care. So a few of those that were not as successful were ones that invited a response of no. So phrases like, I was just wondering, we think that may be sort of best practice because it's person-centered care to ask people or politely initiate care. But that presents a clear sort of interactional opportunity for that person to say no. We also know that people with dementia will have word finding difficulties as well, so can sometimes say no when they mean yes. I've instigated a lot of swallow assessments with patients where I've provided them something to eat and I've said, you know, would you like? And they've said no, but then I've actually placed it in front of them and they begin to eat. Yeah, interesting. The other formulation that wasn't as successful as engaging people living with dementia in their care was would you or can you? So can I listen to your chest, or can you stand up, or can you just move your leg up for me? Because again, you're referencing somebody's ability there. Can you do that? For somebody where they're not in their familiar environment, they're distressed, the most likely answer you're going to get is no, I can't do it. So you're kind of opening up that conversational floor for somebody to say no. You're assuming that their ability or their lack of ability to do something. The phrases that were particularly effective were things such as negotiating or announcing your future action. So I'm just going to do this for you, and then softening it with, is that okay? So I'm just going to give you a shave, or I'm just going to turn you round. Is that okay? So you're still giving that element of politeness and consent, but you're also reducing that interactional space for that person to decline. Another one is proposals. So let's do this together, or let's have a drink, let's reposition you, or how about we try this? Because you're giving that invitational flavor. You're proposing I guess a less asymmetrical relationship. You're making it seem that you're doing something together, and that takes the onus off of the person living with dementia to feel that they have to do all these things on their own. Direct instructions, or conversational analysis will call them bold imperatives. So once you've set up that rapport with that patient or that person, saying things in a direct way. So another sip for me, please, or move your leg this way. So being very clear in your instructions. Long, tangential, wide, and vague instructions will be difficult for a lot of people living with dementia to follow. And the last one was one that they studied was softening phrases. So instead of I'm not sure, instead of saying finish this meal for me, softening that with just finish a little bit more for me, or let's just walk to the bathroom, for example. So putting that just or just a little bit more, again, reduces that onerous on the person living with dementia to have to exert themselves or feel that they are about to complete something that's particularly challenging. And these things seem so small, but they do really make the difference. And when I began training and started using these things in my practice, I realized how effective they were, and how much more I was able to do with that patient. And that also goes hand in hand, of course, with your body language and the way that you introduced your interactions with patients.
Thanks, Abby. That's fascinating. And as I was listening to you, I was thinking, I'll never remember this. We maybe need a bit of hints and tips. We need to get you to write something down about things, phrases to use, because I think once you get the phrase in your head, it's okay, isn't it? Chris, can I just bring you in? Because verbal communication is really important, and Abby talked also about body language. But are there other kind of things we can do? I heard a consultant talking the other day about understanding the person's normal routine and what their best bit of the day is. So if you know they're not good in the morning, if you've got something that's quite invasive, if you need to do a procedure, then do that at the best time. Is that something that you would advocate?
Absolutely. I mean, I've noticed somebody in the chats mentioned about using documents that give you a little bit information about the person's normal likes and dislikes and routines. And I think it's absolutely important. People like to get up a bit later or sleep in later, and actually working within the realms of those confines, we find that we can improve our interactions with people. We often find that people with dementia, particularly on an evening, are often worse cognitively, and we call that collectively as sundowning. So certainly in terms of if we're wanting to get the best out of our patients, often the mornings can be the best time. But that changes from person to person. And I always remember we had a lady who was very not alert during the day. The ward staff weren't sure why, but she was awake all night. And actually, when we got the care document from her care home, she was a nurse who'd worked night shift all her life, and it was perfectly natural for her to be awake all night. And having known that little tidbit of information, actually, we stopped putting her to bed on a night and let her sleep largely during the day. And we actually did a lot of the care and things that we needed to on a night. That lady went from being very highly agitated during the day to being completely settled on a night. And I think sometimes knowing these little bits of information can make a massive difference to a person. The other thing that just to elaborate on Abby's points as well, is I'm a great believer that as soon as you carry that label of having dementia, you tread differently. And we almost treat people in an abnormal way. I'll say to the staff that we do very personal things in a hospital. I'm a very private person, and I would be mortified having, say a member of staff have to do personal things with myself. And I think as soon as you're labelled with dementia, some of that pleasantry goes out of the mind, out of your head. You'll come up and say, I'm going to change your bill, or I'm going to do this. And I find that we would never do that with somebody who didn't have any cognitive impairment. If I was going to go up to a gentleman and do personal care, I would explain who I was, what I'm doing, and why. And I think we forget to do that. And I think another way that knowing a little bit about a person is, you can actually, instead of, approaching the conversation as I'm going to change you can go, "Hi, Bill, I heard you used to work as a miner or in the shipyards. Can you tell us about that?" And they'll start talking about that. And then you say, "Hey, why are you talking about that? Do you mind if I just, check that your pressure areas are fine, or you look a bit uncomfortable? Can I reposition you?" And actually, I have a much more enjoyable conversation with Bill, because I'll find it fascinating hearing about their old jobs. And Bill feels very comfortable while I'm providing that personalised care. And I don't think that we do that enough. I think we see somebody with dementia and it almost goes, "Well, I need to turn you, or I need to change you." And the thing is, there's no context to that. And I often say one of my areas of bad practice is, sometimes when I was a bit more junior, I used to pull the curtains round while the patient was asleep and then wake them and say, "Can I do some cognitive testing with you?" And I used to joke and say, that could be absolutely awful. I've woken an 86-year-old lady up. She's got a male member of staff who she doesn't know standing up, and she's in bed. And if I used to joke to the staff, if I turned up at your, bed at 2 o'clock in the morning and woke you up and said, "I want to do a cognitive test," you would probably call the police. And we joke about it, but actually it's absolutely true. And for that person, that is the reality. She's had a 38-year-old gentleman who she doesn't know turn up and go, wake her up while she's in bed and she doesn't know who I am. And I think we really underestimate that the lack of context of where you are and how it impacts on your decision making. If you look at a lot of people with dementia, the decision making is perfectly rational when you take out the understanding of the context of the situation. And people in healthcare, we get almost sort of dull to doing these sort of complex and personal things to people. But actually, if I was ever admitted to hospital, if I'm honest, one of the things I would be most terrified about would be, one of the staff seeing us in a state of undress or having to do personalised care. And I think it's exactly the same for somebody with dementia as one of the ladies who I was speaking to had said, nobody had seen her in a state of undress since her husband, other than her husband, for the last 40 years. And, here we are to do some personal care. And that having a distress reaction to that is completely appropriate.
But actually, then in terms of a communication strategy and
Yeah.
a settling or unsettling thing. So I used to work in Cardiff, so I used to have to leave very early in the morning because I live in Bedfordshire, and I used to go to get petrol before I left, and I would always see the same lady in her pajamas, which I thought was really weird. And I was chatting to her one day at the till, and she told me she worked in a dementia care home and she was a night carer, and that they wore night clothes to orientate the person to the fact that it was night. We've had a question from Heidi also, which is linked similarly. Do you think uniform works? Do people recognise the uniform, and is that settling or unsettling? Or, can it go both ways?
I think it goes both ways. We have instances where, yes, there's local care homes who dress in night clothes, and I think it works very well for them because you get somebody who wakes up in the middle of the night on a hospital ward and everybody's in uniform and there's a light at the nurse's station. Why would you be asleep? Everybody's in clothes. But on the same sort of ilk, some people orientate themselves to being in hospital by realizing there's a uniform. I think it's very difficult. Some people get fearful of the uniform, so people think we're police officers or we're something like that in positions of authority and can be frightened of the uniform. And I think, you've got to think back to practices in the 1960s in, mental health hospitals and that sort of stigma and fear that sometimes comes through in these patients who are suddenly surrounded by people in medical uniforms and what's going to happen. I think there's absolutely merit in dressing in night clothes overnight. I just think it's very, very difficult to implement in a hospital setting. But I think in a care home setting, it's being used to great effect in some settings. And I think it definitely warrants further exploration.
And I was thinking about, you just said something else that triggered me to think. So, particularly if it's a larger patient, we tend to go a bit mob-handed as well, don't we? We know we've got to change this patient, and we know they're probably going to be incontinent, and we go to them and we'll take 2 or 3 people and have lots of kit with us, and that swooshing of the curtains round maybe. And it's kind of what you were saying, Abby, about softening things and about how you approach things, isn't it? It's thinking about that initial approach and how you frame what you're going to do for that individual.
Yeah, I completely agree. And I think, the best thing in that situation would be to go and introduce yourself and say, do you mind if I get my colleagues to give me a hand, in terms of positioning you? I see situations on the ward where a patient has become quite agitated and there's 5 nurses standing around this one patient saying, will you calm down? If 5 people stood around me and said, will you calm down? I'd feel incredibly threatened. And I think we underestimate how threatening it is. And I also think we underestimate how, as healthcare professionals, how much the power dynamic is in place. You very much almost feel at the mercy of the healthcare professionals. And I think what was interesting, I recently had my father in hospital, and he asked for a set of headphones, because to listen to the TV, and the nurses were so busy, I didn't dare ask them. And I sort of was skulking around because I didn't want to disturb the nurses. And that was the power dynamic against me, is where I wouldn't even contemplate that if I wasn't an inpatient. And I think we underestimate how intimidating we can be.
And the point you made about the male-female dynamic's also important, isn't it? We've always been very down the line about, I can remember when we first talked about male midwives, you are a clinician, you are a deliverer of care. It's not about a sexual orientation, but if it becomes a threatening thing, and I see somebody's posted in the chat and it's exactly this, isn't it? Sometimes a change of face may help. If it's somebody that they might have had a previous bad experience with, or it might not be you, but you might remind them of somebody they had a bad experience in, whether that's similar height, shape, colouring, the tone of your voice, all those things play a part, don't they?
I completely agree. I think, when I was very first started, I mean, I looked quite young, and that actually caused problems in that, people seeing us as a young boy and why am I here? And it caused a great many difficulties in certain situations. But on the other hand, people thought I looked like the grandchildren, and so sometimes that dynamic worked. And I think it's the same being male or female. Some patients instantly gravitate to you because you're male, and I have a better relationship, and it's nothing to do with any prejudice or anything. It's just past experience and different things. And it's the same with females. And sometimes, as you say, a change of face, change of age, change of look. We all have different life experiences and different experiences with different people, and so it's difficult to predict. But definitely trying different people can absolutely be beneficial.
And to bring it back a little bit to the pressure ulcer theme, one of the things that I found the most frustrating was you can have that conversation, you can be the right person, and you can get some kind of agreement, some concordance, and you can reposition the patient. So you might get through the skin check, the application of skin creams, and you go to the reposition, and it all seems quite positive. And you go away, you might talk to somebody else, and you go back, but that conversation has been lost and the person has repositioned. Are there any hints or tips you can give about that communication retention? Is there any way we can get that memory of why they are where they are, or what was asked of them?
It can be very difficult, I think, particularly in unusual situations. So in the memory clinic, we try and set people up into routines. And particularly if we catch people in the very early stages, we set them up with diaries, calendars, and books. What we sometimes do on the ward is we used to write what had happened during that day. As a little bit of a diary for the person. And, we've spoken to this nurse and this has happened, or your daughter's coming at 2 p.m. I think in terms of retention of information, it's just keeping it very simple and, very easy to understand. And sometimes even if you are providing a written account for that person to read on the table, you'll often find that they'll sit and read that information throughout the day, and it can be a great reassurance to them. I think in terms of retention strategies, I think it's just keeping the information simple and having that patience. And I think, as you mentioned earlier when you introduced the session, I think patience is the key. And I think when we're very, very busy, in ward areas or providing care, that patience can be very difficult, but actually it can be more time efficient to have that initial patience with the person than it is to sort of rush in and like a bull in the china shop.
I mean, from your perspective, when you are going to see a patient and trying to get that engagement, are there any things that help with retention? So Chris mentioned like the diaries and things, but if we're repositioning a patient, that's something that's much harder to write down, isn't it? Are there things that would help them?
You can provide written information. Where I work, we use quite a lot of visual images as well, and you can always standardize those as well. So I know that they use it quite a lot in learning disability teams. They have things like now and next boards, where they are sort of sheets of paper and they have a Velcro strip. And then you have lots of different Velcro blocks for different things that happen throughout the day. So whether that's meal times or it could be repositioning. I think things like that, where they're sort of less complex and more symbolic, may help. I think also explaining things to a patient where what's in it for them is the significant part. So you could go into lots of detail about why it's important to reposition somebody, or why it's important that they remain on this particular side, but without giving them clear enough information about what's their end of the bargain in that situation. So I presume that with pressure ulcers, that if somebody is not lying in the right position, that they are more likely to, develop a worsening of their wound, or that, repositioning somebody is preventing those sores. So just simply saying what's in it for them. We're just going to move you so your bum doesn't get sore, rather than, a wide explanation about why you're moving them, or literally we're just going to move you again, so you don't get sore, or what, you're going to get sore there, let's do this. Just keeping that, I guess, awareness that the significance on the person is going to be the end result, the pain, or the more attention that you're going to have to pay to that area or the medication. So reminding that person, maybe. One thing I do see on the ward, just one other thing that I do see on the ward is just something that frustrates me from, I guess, a cognition perspective for our people living with dementia, is that somebody will say something like, "Don't you remember this?" That is probably in my experience, one of the most distressing things that you can say to somebody. "Don't you remember this?" Because the chances are that they won't. And I think sometimes you can, if you're going to say, "Don't you remember we turned you to this position," or "I was here a minute ago and I did this," just cutting off the "do you remember," and just say, "I came earlier and we did this," and it's just recapping what you did, and that being a way of reminding the person what you've said or done without causing distress.
Yeah, because it must be distressing, because quite a lot of people do know they are forgetful. They know there's something wrong, and to remind them that, "Don't you remember?" or "Have you forgotten?" must be very frustrating. I like the idea of the Velcro box. I've not seen that. And we did have some tips in the learning disabilities video, which I think when we talk to the LD nurses, a lot of them cover dementia care as well. And some of the things that I've seen in practice that are really pragmatic things, like if you want them to lie on one side, putting the TV there, or maybe placing food and drink to one side of the table so that they constantly turn that way. But I think it is really, isn't it, thinking about from their perspective, what's in it for them, what might trigger them. So it might be a case of noting their normal behaviours and tying some of those things in. Chris, are the things that you've seen where what you're trying to get is to stop them going against what you've asked them to do, that they agreed to do, that you think you've explained, and we were with it, we were on target with it. So even if they're getting a sore bottom, they're going back to the same side.
I think, with these situations, in terms of what we're talking about really is compliance with something that's something somebody might not necessarily want to do. And I think, as Abby said, it's about explaining it as best as we can and contextualizing that. I think what we shouldn't do is get frustrated with that. And I think if we show frustration, that people can often close the door to that conversation and not engage. I think it's about recontextualizing what we want to do, building in some routines, and use the family. People forget that people are often much more amiable towards the family members. Give them a call. Are they coming in at visiting time? Can we schedule a positional change when the husband or the wife's in? It can make a big difference. Have the family involved in the care if they're willing to do so. Somebody's mentioned as well about music there in the chat, I think Carolyn Brown, and it seems totally, alien to what we're trying to do, but actually having an appropriate music track on while we're repositioning somebody might settle them and make them feel more comfortable and willing to engage in changing that mobilization. I think what's very important about music, though, is it's specific to that person, because what I might like, Abby might not like, or you might not like. And actually, we can make people worse by playing the wrong music. But I think if you get that little bit of background information, it can make a big difference. I think in terms of persuading somebody to do those positional changes, it really is just about patience and spending that time. And I think the other thing as well is giving eye contact and not having the whole conversation about that movement. Come and talk about something else and have it as part of the conversation. I think if I was to say to you, Jacqui, I really want you to do this, you might start questioning, why does he want me to do that? Whereas if I was talking to you and I said, "Oh, would you mind passing us something over there?" You might be amiable to do that. that. And I think it's about distraction and building that comfortable sort of relationship with your patients or people in their own homes. And I think it's much easier in long-term care to do that. I think it's very difficult sometimes in the short stays that we have in hospital where you're in for a week or two to build up that relationship, and especially if there's a different member of staff on every day. So it is difficult, but I think what's very important is that the staff log what worked for them. And document that in their personalised care charts. If I go and they say, "Oh, he was," it was like, but butter wouldn't melt for Chris. He did everything that he wanted. Then actually, why don't I just come at position in time and reposition Bill? But at the same time, Bill might think Chris is abhorrent and he won't turn at all for me. But, say Abby turns up and is much more amiable. And I think it's about that exchange of information with your colleagues about what works, because it might be that Bill really likes talking about Elvis. And if you talk about Elvis, Bill will actually be much more compliant in terms of doing that. And it seems completely unrelated, but actually these are the sort of things and distraction techniques we use, and it can make or break the person actually complying with that positional turn and positional change. But it requires information and it requires really good personalized care.
And lots of things you've talked about there, there's lots of examples of this in the chat, are about comfort, aren't they? If you get somebody into a position and they're comfortable in that position, if they're settled in that position, whether that's, we've got an example in the chat of giving them a teddy bear, or when they get there, playing the right kind of music to them, or having something that they look at that makes them feel safe. Those are all kind of things that mean they're more likely to stay in the position that you want them to be in.
Yes.
And if you put them somewhere and they're not comfortable in the first place, and they're facing the wall, and they've got no interaction with things.
The other thing, I mean, you can reposition pictures that are personal to the patient. So, we'd often ask, will you bring in a photo of when you were married, or, your children, or things like that?
Or your cat,
And
your dog, or
yeah,
things they like.
or a dog. And we actually have therapy dogs come around the wards sometimes, on the wards. And actually, if you say, "Hey, Bill, if you move over to the right, you can come and look at the dog, you'll get a much better view." Sometimes it's about that, or I'll turn it so you can see your photos from this angle and they're looking at the family photos, because it provides a great comfort. It must be absolutely terrifying not knowing where you are in a strange place. But I imagine that if I was in that situation, there was a photo of my wife or my children on the table, I'd get a great deal of reassurance. And if we reposition those and put them within sight of where we're wanting somebody to be positioned, I think it might go a great way in terms of helping them comply with that positional change.
Is that grounding element, isn't it? It's that element of security. The other question that we had was something about the use of virtual reality. So if you're having to do something that might be a little bit more distressing or a little bit more invasive, or something that that individual doesn't like, is that something you've seen used?
It's not something I've personally seen used. We are using a lot more technology. So we use projectors we've got projectors in the hospital that are touch sensitive. So they would, for instance, project a football pitch on the floor and you can kick the ball, or quizzes and things like that. And actually using things like that are of great use in terms of getting people to mobilize and move, because you don't have to move a great deal and you haven't got a football flying about in the bay that might knock over delicate equipment. Somebody's mentioned the project actually in the chat there, I believe. And by using projectors and technology like that, it really, really helps. We actually, I went on to one of our wards a couple of weeks ago, and they had all the patients sat in the centre of the bay with a big football pitch printed out, and all the patients were kicking and they were moving and they were mobilising in the chair. And I mean, that will go a great way in terms of relieving the pressure that they've got on them by moving, and it's done in a safe way, and it only needed one member of staff. I've not seen virtual reality headsets used. We do use virtual reality in terms of training our staff, and we've got special glasses and things that hinder your vision, but I've not ever used a virtual reality headset with somebody with dementia. I'm not sure how that will be taken up. It's something I'll maybe look into after this talk. I'd be really, really interested. But yeah, there's definitely room for use of technology.
I think the other thing that certainly I've heard a lot about, and you alluded to it with talking to about in the conversation, or you were a minor, is purposeful activities. If you've got that kind of knowledge of what the person used to do, if something links to,
Yes.
So we had an example of somebody used to work in a laundry. If you give them towels to fold or sheets to fold,
Yes.
and it is for us, keeping people moving, keeping that mobility, and even just folding a sheet. If you think about the element of picking things up, moving down, there's quite a lot of repositioning activity that goes on with that.
I completely agree. I think, if we look back at all of our lives, people want a purpose. And there's always a purpose to everybody's life. If everybody on this chat will look and think, well, I've got a purpose or something I want to do, and they want that to be meaningful. And an example of a lady, we had a lady many, many years ago who was a domestic, and she was very, very agitated on the ward. And actually, we spoke to her family and said, what can we do about this? And they said, well, she loves to clean. And, we actually let her, help make her own bed. She used to help the domestics when they were mopping the floor, pushing the trolley for them and help them carry the equipment around. And I always used to say, if somebody walked on the ward, they'd be thinking, we're letting the patients help clean the ward. What will people think? But the reality of it is that lady went from being incredibly agitated and upset to being the most loveliest, compliant lady. And she really, really enjoyed her time on the ward. She used to sit and smile and laugh and joke with us at the nurses' station. And you know what? I thought, if that all it took to make that 2 week stay for that lady happy, and on top of that, she's getting physical exercise, her eating improved. She was happy to be compliant with any care that we gave. And I can still remember that lady's name today, and you're talking probably over 10 years ago, when that happened. And I think absolutely giving people purpose and knowing that the background is definitely very, very beneficial.
I think there's that purpose. There's also that recognition of the person's background that we've talked about a few times. I wondered about language. We have local language, we have regional accents and things. Do you think understanding phrasing and nuances that person may be used to, that might be relating to their work, it might be related to where they grow up, does that give comfort to people?
Absolutely. And from growing up in the South and now working in the East Midlands, I do find a lot of conversational breakdowns where I'll say something and the person that I'm speaking to has no idea what I'm on about. And the other way around as well. I think somebody the other day actually referred to a cup of tea as mash. I was asking them, I was doing some cognitive work on how to make a cup of tea and going through the steps, and they said, well, I'd use the mash. Apparently that's a way of it's like a technique, which is where you're like pushing the tea bag against the cup. And I was thinking, that's not right. I can't work out what's going on. And actually it was then that person's next of kin that was telling me about how it's regional phrases. And I think you're absolutely right. It's really important. And I think particularly in these populations where people need to feel that they are in a familiar environment and that they are around people that understand them, I think almost maybe a bit of an induction into the general local or local phrases, I think would be a really good idea, and not just in dementia care, actually in everywhere, because you've got that sort of camaraderie when you understand somebody and somebody understands you. I also think that speaking to somebody that knows that patient, the advocate for that patient, from whether they're in a care home and you're speaking to somebody that knows them very well, or whether it's a family member, any advocate in some form, being able to speak to them about maybe some funny anecdotes or things that that they'll enjoy reminiscing over, maybe not so much as much of the local phrases, but sort of shared stories, and having like a shared focus as well, is a great idea.
And it goes back to where you started from with that friendly approach, doesn't it? If depending on where you are, we use love, a duck, a chuck, or a bab if you're in the Midlands. There's all those kind of things that if it engages people, it might not be what we would normally do, but if it gives that calming effect and it helps, it's really useful.
Absolutely. I think with names as well, I've had a lot of patients that have come in and you call them by the name that it says on the system and they don't respond. And you think, gosh, have I got the right person? And you check, you definitely got the right person. And you find that their nickname or their name has been a completely different name for years. And they won't respond to their sort of, their birth name. So
Shortened names, aren't they? I had one of my mum's friends was called Margaret, but she was always called Peg. And apparently that's a shortening of Margaret. I would never have known that.
absolutely.
If they're Nelly or whatever it is, then you need to get the name right.
And you
Just to bring us back again to this kind of pressure ulcer prevention theme, we briefly touched on, I think, Chris, you said a little bit about the importance of getting them to eat and drink and how, we can tie positioning into social activities like meal times. But is nutrition a challenge in patients with dementia? Is it something, it's one of the things that we have to really focus on?
100%, and I think particularly in the advanced stages of dementia, often one of the primary features that ultimately causes the end of that person's life is loss of appetite, and people simply stop eating and drinking. And I talk about eating and drinking. It's a very, very complex thing that we don't think about. If you were to go to a restaurant, you might spend over an hour in there eating and drinking. It's an enormous amount of time. People with dementia don't have the concentration to eat a large meal that maybe when they've got impaired dexterity and frailty, or they need feeding by somebody, might take half an hour to eat. And so frequently we resort to using finger foods, small items that you can pick up and eat and sit and eat over the course of the day. I think another thing that we try, I try to tell my patients is we frequently focus on having a healthy diet, and eating the right things, particularly when we're younger. And that absolutely is the right advice. But I think certainly in the later stages of dementia, it's about getting calories in and protein in. And, if that comes from somewhere that's not necessarily a traditionally healthy source, then actually it's better than nothing. Um, because eating isn't just about actually taking in the food. Your appetite's affected by the level of activity you've done, whether you're low in mood at that particular point in time, whether your medication's made your mouth dry and it doesn't taste very nice. Some of the other strategies that seem very off the wall is actually using coloured plates. Coloured plates have shown that somebody with dementia will eat 20% more food in the moderate to severe stages. And that's primarily down to some of the visual impairments that happen with dementia. The recognition of the food becomes difficult, but if you've got that contrasting background, they can identify what they want to eat. And also having social activities. Eating's a social thing. We have a sort of a day centre within South Tyneside and Sunderland called the Alexandra Centre, and we sit all of our patients around a big table and let them all eat together. And it's amazing how they chat together and eat. And while they're doing that, they're not only eating more and getting the protein that they require, but they're also moving and they're interacting and they're out of their usual regular seating place. So all these little micro movements and moving somebody from sitting in that confined bed chair area to around a table, it all contributes to that increased mobilization as well.
And is hydration a problem as well? I can remember seeing a good few years ago now, the thing that was on Dragon's Den, the guy who invented for, I think it was his grandma, the little jelly things that were really just water, but they looked like sweeties, so they were more tempting.
Absolutely. To be honest, hydration is a problem in a lot of elderly people. Your thirst diminishes as you get older, and quite frequently we get people in who are drinking sort of a litre a day, and that's normal for them. And the problem is you might get away with that just over winter, but when it becomes warmer and you're losing more fluid way through sweat and things, you often come in dehydrated. I think the biggest thing with getting people to drink more is actually just constantly prompting them. But the other thing that we don't take into account is continence. A lot of people are frightened to drink too much because they may be incontinent, and sometimes the mobility problems and the continence issues you've got, people don't want to take in those fluids, and it can sometimes be the case of making sure that person has easy access to a toilet that can be the difference between them drinking. But yeah, it's absolutely something that should be tracked, and I would definitely advocate monitoring diet and fluid for every patient that comes within an inpatient setting in the acute trusts.
A nice tip in the chat there, somebody's saying if you half fill the glass, then sometimes they think they've already started it, so they'll carry on.
Yeah.
You mentioned incontinence, and in terms of personal care, that's probably one of the most personal things we do for somebody, isn't it? And communicating, so communicating the need to go to the toilet. Sometimes, Abby, do you find that conversation can be slower? So that message transmission to the brain, if I need to go to the toilet, and then the ability, you mentioned this loss of words, this ability to get that message out becomes very urgent, and that might be a cause of agitation.
Yeah, absolutely. And I think it's important to remember that, if somebody is agitated, there is a cause for that agitation. Absolutely. So I always think back to one of my first days, and one of my first days being qualified and making a lady a cup of tea, because a cup of tea puts the world to rights normally. And I had clearly hadn't made it right, but I didn't realize that at the time. She was just declining. And for a good few days, I was trying to assess her swallowing, and every time I make her the cup of tea, she'd decline. Her daughter then came in on the fourth day, because I thought it might be useful, and I managed to coordinate a time for her daughter to come in with to do the swallowing assessment with me. And she said, oh, it's because she doesn't have milk in her tea, she just has black tea, and the tea bag has to stay in for only 10 seconds, and then it has to be lifted out, and the water has to be piping hot. Like the most bespoke, tea making instructions I've ever had. But she wasn't able to communicate that. The person living with dementia, she wasn't able to tell me that. But clearly her reaction and her distress every time I put the cup of tea down, was a big deal for her, and ended up being a difficulty for us as well, because I couldn't deliver that care that I needed to, and just being able to speak to the advocate for that person, or maybe on reflection, if I'd had more of a simple, structured conversation with that person, I may have got to the solution quicker. I think just going back onto what Chris said about finger food, we know that obviously personal care can feel very invasive, but also the process of being fed by somebody is actually a very intimate experience. I don't know if you have ever been fed by somebody, but it's something that we always do with our training of agency staff and other healthcare professionals. We ask them to feed each other. And everybody talks about how intimate of an experience it is. You need to pick up on that person's cues to know that they're ready for more, or to know that they've swallowed, or that they've had enough, or that they'd like a few more of the peas rather than the broccoli. It's actually a very intimate experience. So being mindful of that can actually improve somebody's oral intake, if you're being mindful of the way that you're providing them with food and drink. I think also with finger food, really ideal because you're promoting that person's independence. We normally talk, when I assess people in the hospital, not just with dementia, but any background, we always talk about promoting independence. I like to be able to choose how much I pick up on my spoon, or how much I put in my mouth at one time, or what I pick up from the plate.
Or what combination. People can be very funny about if you put
Absolutely.
have their food touching, will they? So if you put
Absolutely.
peas and mash on the same spoon, that might not be.
My dad likes to eat his favourite thing last on the plate, and he saves it. I never understand it because it probably goes cold, but that's just him. And if somebody didn't know that, and that were to distress somebody, then you're really sort of ruining that experience, because eating and drinking is a very personal thing. Yeah.
Yeah, so I'm really conscious that the hour's gone by. We've got 2 minutes left. It's been really, really fascinating. So I just wanted to thank you both for your engagement. And I guess for both of you, pressure ulcer prevention is not your primary topic. Certainly, Abby, for you, it's not. But Chris, I guess it's a bit more high profile on yours because of the frailty of your patients. Is there one kind of final message you want to give, given that it's Stop the Pressure Day, for your patient group? Is there one really major thing you think we could do that might make a difference? Chris, do you want to go first?
I think we really need to provide activities, mobilisation activities within the acute setting. We used to do chair aerobics and things like that, and I think it's very easy for staff to do. It's something simple, it's something fun, and I think if you could go away from today and just get your patients to mobilise a little bit more, then that would be great.
Abby, any one tip from you?
I think just remembering that person-centered care flower for caring for people with dementia, and reminding yourself in the middle it says love, and that doesn't need to be romantic love. It can just be making that person living with dementia feel love and feel cared for. I imagine that will improve compliance and engagement in care, absolutely, and experience as well.
What a lovely way to end. Thank you both of you for your time and for really engaging with us. Thank you to everybody who's joined us. I hope you found it useful. If you want to watch again, or if any of your colleagues want to watch, it will be available online. Thank you, everybody. Good night.